Welcome everyone to our talk today. I'm very pleased to introduce Dr. Daniel Hsia, who's an associate professor and associate division chief of endocrinology in the Department of Pediatrics here at Emory University. He's a board certified physician in adult and pediatric endocrinology, as well as in obesity medicine. He completed his residency in medicine and pediatrics at LSU Health Sciences Center in New Orleans and completed his dual endocrinology fellowship at Baylor College of Medicine and Texas Children's Hospital. His research focuses on the prevention and treatment of diabetes and obesity across the lifespan. And over the past 13 years, he has led or collaborated on dozens of clinical trials that have translated interventions and approved therapeutics from adults to children with diabetes and obesity. And with that, I will pass it on to Dr. Hsia. Thank you.
Great. Thank you, Lisa. Really appreciate the introduction. Thanks to Wendy for setting up the presentation and the invitation from the Emory Global Diabetes Research Center. It's just a real privilege to be presenting as part of this seminar series. So let's see. Advance. There we go. So before I start, just a couple of disclosures. I do conduct clinical trials for a variety of different sponsors, whereby the institution is paid via contracts. I am a consultant for Eli Lilly for their pediatric chronic weight management portfolio. I will discuss some off-label use of medications in my talk. And just again, for this audience, it's probably not necessarily relevant, but children are not small adults, and I'm going to sort of explain to you why that's the case, particularly in the area of type 2 diabetes. So a quick overview of the discussion. We'll touch on pathophysiology of type 2 diabetes. I think this figure off to your right really illustrates all the different and just some of the components that are contributing to the development of type 2 diabetes in our pediatric population and some overlap into the adult population as well. I'm really going to focus on the development of complications in our youth and young adults. And then so we'll also talk about screening and diagnosis even before we get to the treatment and complications part, but what are the current treatment options that are available, and then really end talking to you about updates and sort of future directions, at least from my standpoint and from what others are really looking at in this area. So I start out with these global trends, really taking a look at, so if you look on the left side of the slide, this is the global prevalence of type 2 diabetes per 100,000 kids less than the age of 20. So you'll see Brazil actually has the highest prevalence, currently, and you can see the sort of the distribution of the different countries. The right is the font's a little smaller, but that's the global incidence of type 2 diabetes among children and adolescents per 100,000. And so I just blow this up because we are one of the top three countries in terms of rising in the incidence of type 2 diabetes, along with India and China. And this is now, even some of this data is a little bit dated, but this is the most recent data from the International Diabetes Federation. So in terms of pathophysiology, type 2 diabetes is characterized by a progressive loss of beta cell function in the setting of insulin resistance. And certainly, this is not a one size fits all. There are different degrees of and the rapidity to which beta cell function is lost and to the degree of how much insulin resistance is present in each individual patient. But typically, there's a decline in beta cell function anywhere from 20 to 35% per year, compared with a decline of about 7 to 11% per year in adults. So you can see that we do have a significant amount more of beta cell decline in our pediatric population. And then increased adiposity is a major risk factor for insulin resistance. And then again, at the absence of pancreatic autoantibodies, which I'll touch on a little bit later, and why that complicates the diagnosis. We also have a dysregulation of other hormonal pathways like glucagon and incretins. Obesity induces underlying inflammation. So these young people have higher levels of CRP, tumor necrosis factor alpha, as well as interleukin 1 beta. And on top of that, children can have these adverse childhood experiences and trauma that we know that increase their risk for development of diabetes. And then there is a rapid progression to diabetes-related complication, even more quickly than in our adult populations. So what do I mean by that, and how do you sort of quantify that? So this is data from the Today study, looked at nearly 700 adolescents diagnosed at an average age of about 13 or 14 years, and they were able to follow these kids for about 10 to 15 years in some cases. And what you see here is that the incidence of complications. So by the time at the end of their follow-up, most of these kids had some degree of whether it was hypertension, kidney disease, dyslipidemia, nerve disease. And if you look at figure B here, any sort of microvascular disease was present in about 80% of these young people. Now you have to realize that these are kids who were diagnosed with type 2 diabetes, who had a follow-up. So these kids are now in their mid-20s, and 80% of these kids already have microvascular disease present. And then I just wanted to touch a little bit on COVID and the effect of COVID-19 on the development of type 2 diabetes. I was part of this registry study that included 24 children's hospitals across the country. This was back when I was in Louisiana. And we looked back and we noticed that the risk for the diagnosis of type 2 diabetes was 1.5 to 3 times higher following a COVID-19 diagnosis compared to even other kids that were diagnosed with other respiratory infections. So it really still remains to be seen. Was it really the infection due to COVID? Was it all of the lockdown measures? We're still a debate, going on as to the why do we have such a significant rise in the incidence of type 2 diabetes with COVID. And then I wanted to share some local trends. I know we want to look big picture, but I think it's always good to look at our own numbers here locally. So this is at the Children's Hospital here, and you can see that if you look at 2021 all the way on the left side, all the way to the first quarter of this year, certainly a spike in the overall diagnosis, and in particular, if you see all the way to the left, the numbers of new onset cases of type 1 and type 2 diabetes almost matched each other during COVID. So, and you can sort of see that steady fall back to about somewhere around a 3 to 1. So now, type 1 diabetes still remains more likely in our pediatric populations. But we're diagnosing, about 40 kids or so, 40 to 50 kids per quarter with type 2 diabetes. And then in terms of screening, this is based on the American Diabetes Association recommendations, but it's really risk-based. So typically that is after the onset of puberty or 10 years of age, whichever occurs earlier. And these are going to be in kids that have overweight, so a BMI at the 85th percentile or greater, plus one other risk factor. So maternal history of diabetes or gestational diabetes, family history of type 2 diabetes, and a first or second degree relative. There are different races and ethnicities that are higher risk, particularly Native American, African American, Hispanic, Asian American, Pacific Islander. And then signs of or conditions associated with insulin resistance. So things like acanthosis, hypertension, dyslipidemia, polycystic ovarian syndrome, or small for gestational age. This is just to say that these are the cutoff values for screening for prediabetes and diabetes. Most are familiar with these numbers. So being able to use a fasting glucose, a 2-hour glucose from an OGTT, or hemoglobin A1C. The key here is that if screening is normal, you still want to repeat screening at a minimum of every 2 years, or more frequently if you notice that the child's BMI is steadily increasing. So, what about diagnostic challenges? So, really, we've really run into a difficulty distinguishing between patients with type 1 and type 2 diabetes in youth. So, the prevalence and incidence of overweight and obesity remain common throughout. So, even in kids with type 1 diabetes, uh, you can be fooled. There are certainly kids with type 1 diabetes who have obesity and are overweight. And then, diabetes associated autoantibodies and ketosis can be present in youth with clinical features of type 2 diabetes. So just because you have, you know, DKA or diabetic ketoacidosis doesn't necessarily mean that is an automatic, oh, this person has type 1 diabetes and doesn't have type 2. There is a group of population of kids with type 2 diabetes that still develop ketosis. And then at onset, DKA occurs in about 6% of youth aged 10 to 19 with type 2 diabetes, as I said. And it's really important to make this distinguishing, being able to distinguish between the two types, really for treatment, education, nutrition, and certainly for outcomes, which we'll talk about later. And then, although uncommon, type 2 diabetes has been observed in prepubertal children less than 10 years of age, and it should be part of the differential in kids that have, suggestive symptoms like polyuria or polydipsia nocturia. I myself, very recently, last couple of months, diagnosed a child age 7 with type 2 diabetes with negative autoantibodies. And so it doesn't happen very frequently, but it's certainly a possibility. And then youth with overweight or obesity being evaluated for type 2 should have a panel of pancreatic autoantibodies tested to help exclude autoimmune type 1 diabetes. And up to 10 to 20% of children with type 1 diabetes who are considered insulin dependent are going to be autoantibody negative. So you can see where this diagnostic dilemma or multiple diagnostic dilemmas can occur. And then, understanding that we also need to assess for something called hyperosmolar hyperglycemic syndrome in youth who present with blood sugar greater than 600. And these kids are severely, severely dehydrated, and you have to really be careful about lowering their blood sugar too quickly. Otherwise, they will develop, cerebral edema or swelling in the brain. So here's our management algorithm. I won't go into too much detail, but this is what is in the guidelines. So the American Diabetes Association publishes standards of care every year. I always look for them, and they get published in January. And so this is the latest sort of algorithm. The main things here to point out is that there is a cutoff in terms of A1C and where we really get, sort of concerned and how do we the treatment intensity to start out off with. So if you have a kid with an A1C less than 8.5 that has no acidosis, being able to start metformin first, and then checking autoantibodies, as I mentioned earlier. And if they're negative, we're going to continue down that left, pathway. And then there are other treatment options that we'll talk about. That middle sort of column, looking at an A1C greater than 8.5% with no acidosis, no acidosis with or without ketosis, starting metformin, and then potentially starting insulin for these kids because of how high their A1C is to start. And then the last column with acidosis and or DKA, you got to manage the acute issue there, and then starting with IV insulin, and then transitioning to subcutaneous insulin. And then again, looking at the autoantibodies, if at any point that those are positive, you would continue and treat as type 1 diabetes, and you would stop, metformin if you had started it. And then just to touch briefly here locally in terms of referral to our division, we really need those results, right? Of fasting glucose and A1C. We're always looking for growth charts, and then what's the acuity of the child's condition? Do we want to go ahead and start metformin, off the bat, just even before they come in to see us? And then sort of setting expectations that they're going to go through our type 2 diabetes outpatient program and education. If their A1C is too high, we may be sending these kids directly to the ER for further evaluation and admission for insulin initiation. And then, of course, regular visits over the every 3 months in our clinics. So just some general treatment concepts. Really need to consider as really for everyone, healthy lifestyle behaviors, talking about diabetes self-management, education, when to check blood sugars, how to check blood sugars, what to look for, avoidance of therapeutic inertia, waiting too long and not starting treatment soon enough. And then looking at social determinants of health, like what are some of the barriers to treatment that we really need to be aware of? It needs to be patient-centered, a shared decision-making with the family. And then the other things that really should guide your choice are there already comorbidities present, like cardiovascular or renal? What about the effectiveness of the medication you're going to reach for? What is a glucose-lowering effect? What is a hypoglycemia risk? Certainly insulin would have the highest hypoglycemia risk. Are there other risk factors that we need to be aware of? The impact on weight, costs and access, and then adverse reactions and tolerability of the medications themselves. We have to remember that type 2 diabetes is a chronic progressive disease. We cannot simply derive the care routinely provided to adults and translate that into children and youth. And there are different medications that have different mechanisms for lowering glucose. And so how do we best target that individual patient? And so really this figure to show that we're really trying to add medications over time in order to lower that hemoglobin A1C level. In terms of lifestyle management, every family should receive comprehensive diabetes self-management education. Lifestyle intervention with a focus on long-term weight management should be offered. And then for all youth with and without diabetes, right, 60 minutes of moderate to vigorous physical activity every day. We talk about a balanced eating pattern that emphasizes consumption of nutrient-dense foods with a decreased consumption of calorie-dense, nutrient-poor foods. And so this is really important, obviously, in terms of this long-term weight management, in addition to the treatments that we're providing. So, what are the treatment goals? In terms of excess weight, we're really looking for that 7 to 10% decrease, so that we can hopefully help revert these kids back, whether it's back to pre-diabetes or in some case really back to normal glycemia. Blood glucose monitoring should be individualized depending on the treatment regimen. This is maybe they're only having to check once a day if they're only on a certain, metformin or even fewer times a day if the hypoglycemia risk is low. CGM should be offered for youth on multiple daily injections or on insulin pump therapy. This would be really the same for our patients with type 1 diabetes, and we're finally getting some traction with insurance companies to offer these devices to our kids, especially on insulin, but even now to some that are not on insulin. And then glycemic, status should be assessed at least every 3 months. And we should consider an A1C goal of 6.5% or less for these kids with type 2 diabetes and a low risk for hypoglycemia. Certainly, you don't want to have to sacrifice, frequent hypoglycemia in order to get to this goal. But for a lot of these kids, they can reach this, and the lower the better in terms of A1C in this population. And then those, have higher risk for hypoglycemia, you may need a higher A1C goal. So let's move on to pharmacologic management. What are the options? There's only a handful, and 4 FDA-approved drug classes. So insulin, of course, metformin, GLP-1, receptor agonists, which we're learning more and more about in this population, and SGLT2 inhibitors. So again, remember that we initiate insulin when diabetes type is unclear or ketoacidosis is present or when the A1C is 8.5% or more. Otherwise, thinking about initiating metformin as your first line if renal function is normal, and that's pretty much how everyone is managing these patients. So if you can't meet those glycemic goals that we talked about with metformin plus or minus basal insulin, then we can start a GLP-1 receptor agonist, either exenatide, liraglutide, dulaglutide. These are the ones that are FDA approved currently, or an SGLT2 inhibitor, so empagliflozin or dapagliflozin in youth 10 years and older. You want to maximize these therapies before initiating or intensifying insulin, mainly because insulin is anabolic and it can contribute to additional weight gain. And so, considering the addition of these medications that are certainly weight neutral, or in some cases, will lead to weight loss. And in youth meeting glycemic goals, you may consider tapering the insulin, over weeks to months by decreasing the dose of 10 to 30% every few days. Unfortunately, it's hard to predict who we can do this, for who will actually be able to titrate down their insulin. We do have several patients that essentially will develop a remission of their diabetes. And so it is important to be on the lookout for that. So it's not that they're committed forever and ever on insulin. And just to talk briefly about the incretin system, we all know about the incretin effect. So there's greater insulin stimulatory effect after an oral glucose load versus an IV infusion of glucose, especially when glucose is matched. And so this is really how we came up with, and why blood sugar, yeah, it does better, if you are being able to ingest it orally versus IV. And the majority of this incretin effect is due to these two GI hormones. We've gotten to know a lot more over the last few years, GIP and GLP-1. The basal levels of incretin hormones are low, but the levels increase to augment insulin secretion after eating. So these are considered nutrient-stimulated hormones. Patients with type 2 diabetes have a significant reduction of the incretin effect, but GLP and GIP levels after meals are not reduced, especially in patients with type 2 diabetes. So in general, there's an incretin resistance that develops in these patients as well. So here, just is a figure of sort of what are some of the effects of GLP and GIP, GLP-1 and GIP secretion. And you'll notice that the one other hormone to mention or enzyme is DPP4. That is the enzyme that breaks down GLP-1 and GIP that makes them inactive. But they're acting on beta cells and alpha cells to increase insulin secretion and then decrease glucagon. And you can see in the table here that they both stimulate insulin secretion. GLP-1 is the main one that inhibits glucagon secretion, that also delays gastric emptying, that induces satiety, and they're again both broken down by DPP4. So I'll touch briefly on the clinical trial results from the dulaglutide study, which was published in the New England Journal back in 2022. This led to the FDA approval of this medication. And you can see here that really at the highest dose of 1.5 milligrams, you're seeing a placebo-subtracted reduction of about 1.5% in the A1C. And so you are getting pretty significant A1C reduction. But if you look on the right panel, you'll see that that's with really very little weight reduction at all. This is BMI, and you can see here that there's very little change in BMI in any of the groups with dulaglutide, which is one of the more interesting things for a GLP-1 agonist, and this particular one not leading to a very much weight loss. We are actually in line to do another study looking at the higher doses. So for those that treat adults, dulaglutide can be used at 3.0 milligrams and 4.5 milligrams. And so we'll be looking at that in this youth with type 2 diabetes in the next couple of months. So here again, it's just a table to say these are what are approved for 10 years and up, you'll notice that Ozempic, which I'm sure a lot of us are familiar with, is not FDA approved in this age group. And so there is no plans to really develop Ozempic for type 2 diabetes in youth. I don't know a reason as to why, but there aren't any trials looking at injectable semaglutide. There is a study with oral semaglutide that is being conducted actually here as well. We're one of the sites for that study, and these are teenagers with type 2 diabetes. So there may be down the line an FDA approval for oral semaglutide for type 2 diabetes. Oh, before I get into SGLT2 inhibitors, what I didn't mention, I didn't have necessarily a slide for, but you'll notice that there are no approved medications in the DPP-4 inhibitor class. And the reason I didn't show any data because there's very little data, and much of it is negative data, unfortunately, that there is almost no A1C lowering with the use of DPP-4 inhibitors in this younger population. Whereas in adults, we have a number of DPP-4 inhibitors that are available, and of course they're great because they're an oral medication. They don't have to be injected. So just to say that, and just to make sure that I mentioned that before we move on to SGLT2 inhibitors. So this class is really, we're finding out more and more from really a renal perspective and sort of the renal protection of these medications. So it really acts in the kidney itself at these receptors, and it reduces glucose reabsorption. So the most important thing for me in these medications is the fact that this is done in an insulin independent manner so that you don't need to depend upon the secretion of insulin for glucose lowering to occur with these medications. And so because there's increased reabsorption of glucose, reduced absorption of glucose, excuse me, you're having this increased glucose excretion in the kidneys. And that's how the glucose lowering occurs for SGLT2 inhibitors. And here's the data from the Dynamo study. This enrolled about 260 adolescents with type 2 diabetes. And you can see that at the week 26 time point, there's about a 0.8% difference, reduction in A1C after both groups started at around 8%. And then there's follow-up that fairly durable A1C reduction out to 52 weeks. So the starting dose for canagliflozin is here, 100 milligrams, dapagliflozin, 5 milligrams, and then empagliflozin, 10 milligrams, and then the erdagliflozin is the other SGLT2 inhibitor. But again, the two that are approved in kids 10 and up are DAPA and EMPA. And I think that we will be seeing more trials in the pediatric population to better understand how these drugs can be more renal protective. And also, these are being used by cardiology to treat heart failure because there's an indication in adults to improve heart failure outcomes. So I'll move briefly to metabolic surgery. So adolescents, with a BMI greater than 35 or 120% of the 95th percentile, whichever is lower would qualify, with comorbidities would qualify, or if you have just an absolute BMI greater than 40 with or without comorbidities of obesity, you would qualify for surgery. The figures below are really the 10-year data from a study called Teen Labs. This is a longitudinal follow-up of teens that had bariatric surgery, either sleeve or Roux-en-Y, a very small percentage with bands that actually they haven't showed the data, but really just seeing that the durability of the BMI reduction for both procedures is really, very consistent with and somewhat even better than what we see in adults. And on the right, you can see the remission of these comorbidities. So type 2 diabetes, hypertension, dyslipidemia. So at 10 years out, about 60% still have remission of these comorbidities. So, it's again very significant, and even somewhat better than what we see in adults. And I'll come back to diabetes related complications to really sort of compare and contrast our populations with type 1 versus type 2 diabetes. And you can just see that diabetic kidney disease is really one that, 19.9 age-adjusted prevalence versus 5.8 for type 1 diabetes. So, increased odds of 2.58 times more likely to have diabetic kidney disease in our patients with type 2 diabetes. And this is data from Search for Diabetes in Youth. And you can see, again, the differences where increases really higher rates of retinopathy, peripheral neuropathy, autonomic neuropathy, arterial stiffness, hypertension, significant comorbidities that we all should be looking for. So, and then I'll just briefly touch on the screening and how we treat our complications. But certainly we have sort of recommendations from the ADA and others on how we should screen for these complications and how to really make sure that we're not missing something in clinic. And so a lot of these comorbidities are present even at diagnosis. And so you're monitoring or checking for hypertension, neuropathy, retinopathy. Whereas in patients with type 1 diabetes, there are recommendations to wait, 5 years sometimes before we even start screening. These patients already have a percentage of them already have a good deal of complications. And so again, just to touch on this very briefly. And the other things that we also screen for, such as dyslipidemia, MASLD, also fatty liver disease, obstructive sleep apnea, polycystic ovarian syndrome in our females. Again, looking at diagnosis. These are complications that can be present. A lot of them can be screened for annually, or in some cases, like sleep apnea, every visit. And then we have targets for dyslipidemia that you can see there: LDL less than 100, HDL greater than 35, and triglycerides less than 150. I touch on that because it's really important to consider initiating statin therapy, especially for those that are 10 years and older, but making sure that we are counseling our patients because our statins can be teratogenic. And so, okay. And then moving on to just psychosocial factors, making sure that we screen for food insecurity, housing stability, health literacy, financial barriers, and social community support, because those are important in how we decide upon our treatment decisions. Use age-appropriate, standardized, and validated tools to screen for diabetes distress, depressive symptoms, and behavioral concerns. We're very fortunate that we have psychologists, even in our clinic, embedded in clinic, that we can reach out to or refer to counsel these patients. And then starting at puberty, preconception counseling should be incorporated into routine diabetes visits for all individuals of childbearing potential. And then transitioning from pediatric to adult care, I think this is really another area that's ripe for research. I know that even for kids with type 1 diabetes, this is an evolving sort of paradigm. There's really nothing that has been sort of set in stone that we can all follow, or a type of transition program for this type of transition of care. But a lot of times the shift in care is very abrupt. So it's not like this guided or a planned sort of transition. It's, oh, well, they were in pediatric clinic and then maybe they ran out of medications, or they end up in the emergency room. And so that's how you can't see pediatric care anymore because they're 21 or whatever, in terms of their cutoffs for different clinics. So it's really something that obviously would be much better served to have a plan in place. And so there's many lapses in healthcare, deterioration in glycemic stability, increases to acute complications, psychosocial, emotional, behavioral challenges, emergence of these complications. And really, coordinated planning should begin in early adolescence, and really for the successful transition, at least a year before transfer. And so we're doing our part to develop a sort of transition education program that actually we will sort of cycle through different topics for our kids with diabetes. And so by the time it's been 3 or 4 years, they've kind of covered all the different topics that help them to be ready to make that transition. So no one system or plan is better than the other. So love to hear more about this and people's thoughts about this certainly. And trying to actually had an email just the other day from Dr. Pascal and Dr. Davis about this. So, all right, so I'll finish up my talk with just what's on the horizon and what's the latest and greatest for in this population. So I'll start with small molecule GLP-1 receptor agonists. So these are they're oral medications, and so they're going to be pills that we can take that will bypass maybe some of the digestive processes because of the chemical structure, but have similar effects of our injectable GLP-1s. And so you can look and see the difference, though. I sort of pointed out here the dose of injectable semaglutide is 0.5 to 2 milligrams. The dose for an oral semaglutide is 7 to 14 milligrams. So you can see how much more of the active medication you need to get, to take by mouth in order to get similar effects as an injectable. Other dual receptor agonists, so tirzepatide, y'all may have heard of this, stimulates insulin secretion in a glucose-dependent fashion, reduces fasting and postprandial glucagon, improves insulin sensitivity, and decreases food intake. The starting dose is 2.5 milligrams, and then after 4 weeks, the dose is increased, and you can increase, up to a maximum dose of 15 milligrams in this case. This is actively being studied in patients with type 2 diabetes in the pediatric population. And we actually hope to see a report out, hopefully by next year or the year after. This is data from SURPASS, which is the adult studies with type 2 diabetes. And you can see the degree of A1C reduction, over 2% A1C reduction with this dual agent. And then the differences even head to head versus semaglutide versus degludec, which is a long-acting insulin, and so is glargine, and then versus placebo. And so you can really see that there's even differences amongst the agents that we have approved. And then on top of that, you get the weight loss benefits. So you can see across the SURPASS program, the amount of absolute weight loss and then the percentage of weight loss. So this is in patients with type 2 diabetes. And so at the highest dose, even tirzepatide versus placebo, we're seeing about an 11% weight loss that is occurring. And so again, a really dramatic because we also see that patients with type 2 diabetes, that weight loss from some of these drugs may be attenuated as compared to those without type 2 diabetes. But certainly this can help with putting their diabetes in remission as well. So as what we talked about earlier with the degree of weight loss. So some research questions I wanted to pull out. So, in this population, who are at most risk for developing type 2 diabetes? How do we identify the kids with obesity who are at the highest risk? And how do we, direct all of the resources so that they don't progress to type 2 diabetes? Again, so what can be done to prevent the conversion? Once you have prediabetes, well, there's a part of that population that will stay with prediabetes. Another percentage will go on to develop type 2. And there's another percentage that will go and revert back to normal glycemia. And so what is the ideal prevention measures? And then what are those factors that predict diabetes remission? And then as we talked about, what are some other benefits of excuse me, of GLP-1 agonists beyond glycemic control in youth? We have seen all sorts of benefits with the GLP-1 agonists in reducing sleep apnea, in decreasing cardiovascular outcomes. What does that look like for our youth? Do they have similar reductions in some of these other non-glycemic, outcomes? And then who are at the most risk for developing complications? Again, so once they have type 2 diabetes, where do we direct resources, or how can we identify those kids that are at the most risk for complications? Because ultimately, that's really a cause for morbidity and mortality in these patients. And then future directions. So applications of these therapies approved in adults to children with type 2 diabetes. That is certainly ongoing research. We are working with a variety of different sponsors to bring these drugs to market. I think it's obviously important that when adults have 40 plus different medication options and combinations and things, whereas we only have a handful for our youth with type 2 diabetes, that's where we're heading. Optimizing the selection of therapy for these individual patients to maximize the benefit and to minimize risk. And I put in parentheses here, precision medicine, because I think that's ultimately what we're trying to get at with our patients in terms of diabetes treatment. And then combination therapy from the start to preserve beta cell function. You guys saw that these kids develop complications that much earlier than adults. How do we preserve, endogenous beta cell function to hopefully maybe that is what leads to decreasing these complications, and then the continued advocacy for access to medications for all patients. So you've heard in the news and we've talked about and just how difficult it is to access medications. These specifically are newer medications such as GLP-1 agonists, and so making sure that patients can get these really important treatments. So with that, I will finish and I will leave some time. I think it's for questions and discussion. So thank you.
Okay, Sarah, go ahead and unmute, ask your question.
Sure. Hi, Dr. Daniel. Thank you so much for such a great presentation. I'm a current third-year PhD student in the Nutrition and Health Sciences program here at Emory. And I'm very interested in both diabetes and childhood obesity. And I have two questions. My first question was specifically to the slide regarding the glycolipids. Can't pronounce that.
Glutide? Mm-hmm. Yeah.
Slide 24, you said that you didn't see any differences in BMI,
Mm-hmm.
but I was wondering if you looked at any other body composition like fat percentage or muscle mass.
Great question. So these diabetes studies they're really focused on the glycemic outcomes, and the weight ends up being a secondary, outcome. We are doing more and more to try to understand the change in body composition because I really feel like that is a huge hot topic in understanding these GLP-1 agonists specifically. But no, in that particular study, there was no measurement of other measurements of body composition specifically. So yeah.
Okay, thank you.
Mhm. Would you have another question?
Oh, my second one was actually a
Oh,
comment.
oh, okay.
I'm from Kuwait and I work at a diabetes center, and we have a pediatric clinic and as well as an adult clinic. And I'm also curious to see how these patients transition from the pediatric to adult clinic. So I
Yeah.
might email you about that.
Yeah, that would be great. I know that in other parts of the world where there's a lot better communication with electronic medical records, continuity of care. I mean, basically they have registries since you're born, and they follow you. You're able to be followed, throughout into adulthood. We unfortunately here in the US don't have such great continuity, and it's just going from medical system to medical system, and you get parts and pieces of different people's records. So there are a lot of inherent barriers to continuity of care, unfortunately. So
Thank you.
thanks.
We have a question in the chat. Thanks for an amazing presentation. Does the lesser effect of incretin mimetics inducing weight reduction in patients with type 2 diabetes have to do with the incretin resistance you described? Do you find that they require titrating to highest dose to overcome that?
Yeah, that's a great question. So there's that, the incretin resistance, and just the inherent insulin resistance that it develops with type 2 diabetes. Regardless of how you lose weight, losing weight once you develop type 2 diabetes is really difficult. And then you superimpose that with other treatments that further increase insulin, or you're giving exogenous insulin, and weight loss just becomes that much more difficult. So no matter whatever trials you look at, we'll just use semaglutide, for example. If you take patients who don't have diabetes, they're losing about 5%-ish more in their body weight as compared to those with diabetes. So.
And next we've got Lisa. Please go ahead and ask your question.
Thanks. That was a fantastic talk. I was very interested in the point you made about the DPP-4 inhibitors, that they were not effective in kids. Is there a sense out there as to whether it was like just a single study that showed that, or was it more like there may be some biological reason that there may be, like, for example, less DPP-4 is secreted in kids? Is there some kind of age relationship with that? Or is incretin release like uniquely poor in kids because enterocytes aren't developed or something along those lines? Like,
Yeah. No, so it's not a single study. So I will tell you, the first DPP-4 inhibitor, I actually remember because I was in fellowship and I was trying to develop a project around sitagliptin, which is called Januvia, the branded Januvia, which is actually coming off patent, I believe. But there were multiple studies actually looking to see if that would be helpful. I just participated in a study with a drug called allagliptin in the same family. That, to me, it was where there was no A1C reduction, but in the placebo group, there was a slight increase in A1C. So it didn't meet the FDA criteria to drop the A1C by at least half a percent in and of itself. So, the company's never really moved forward with trying to get approval. So while to me, A1C stability is good, compared to, A1C rise, from the data that I've seen, that's been the issue with these drugs. You don't get a huge reduction in A1C. And I think it has something to do with potency, potentially, although I haven't looked at some of the PK, studies in these particular drugs, but it's multiple DPP-4 inhibitors. So it looks like it's a class. As a class, they don't lower A1C. And you brought up some great potential ideas, Lisa, and we haven't really dug very deep, to be honest with you, to look at why DPP-4 inhibitors are not effective in youth with type 2 diabetes. So
thank you.
Mega, go ahead with your question.
Sorry, I was trying to turn my video on. Hi, this is a great talk. Thanks so much. I had two questions. Hopefully that's okay. My first was, in your initial slides talking about kind of the management of diabetes in pediatric patients, you had something on there about how 10 to 20% of type 1s might not have pancreatic autoimmune antibodies, right?
Yeah.
And I was curious, is there a role for monitoring these patients, rechecking antibodies over time? Will they at some point sometimes revert, go positive, and then you're going down a different treatment algorithm then, or if they're negative, they're just negative?
So let's divide the population. So you have a group of patients who appear to be insulin dependent. In other words, they will develop DKA. Their blood sugar rises significantly if they go a few days without insulin. In those patients who have negative antibodies, we treat them as they have type 1 diabetes. We really don't repeat antibodies, and I don't know of any data to say that we should be repeating antibodies. I really think that they have an antibody that we're not checking for. So, there's 4 that are commercially available that we can check for, and that covers about 85 to 90% of, every kid with type 1 diabetes. But then you have this 10 to 15, maybe up to 20% of kids that will come up antibody negative. For the kids with type 2 diabetes, who traditionally they're antibody negative, they have all the signs of insulin resistance with acanthosis and other things. Those kids, we check them to make sure that they don't have type 1, that we've missed something. And because we also, in the Today study, there was a percentage of kids that were antibody positive who, again, their doctors had diagnosed them with type 2 diabetes before they entered the study. And those are the kids that failed metformin first and that required insulin first out of the entire population. And that was very consistent across the board in that particular study. So, but yeah, to answer your question, I don't know of any sort of sequential or, routine measurements of antibodies. We can have a different discussion about identifying kids like with diabetes, stage 2, type 1 diabetes. I can come back and maybe give another talk about that. So, but
That's
yeah.
great. Okay, sorry. And my second question.
Yeah.
So I'm a family doctor by training,
Yes.
and I do a lot of diabetes research.
Yeah.
And I know you mentioned that semaglutide is not FDA approved for type 2 diabetes in youth, but
Yes.
Wegovy is approved
Yes.
for child obesity for 12 and up.
Yes.
Right. And was sitting in on a Novo Nordisk panel where they wanted feedback from primary care providers about prescribing Wegovy
Yeah.
in 12-year-olds. And across the board, it was family doctors, pediatricians, endocrinologists. Everyone felt very uncomfortable. Nobody was like, I feel really good about prescribing Wegovy to a 12-year-old. And so I know we talk a lot about from the patient perspective and the cost perspective, but part of it is also that you have to find somebody that feels comfortable prescribing these medications. I'm curious about your kind of perspective on that, the ethics of it. I think a lot of the pushback was, listen, you're talking about putting 12-year-olds on medications that have been tested in clinical trials for 12, 18 months. And we're talking about a lifetime of medication for a 12-year-old. And so I'm just curious about your thoughts about that as well.
So, I came up in the generation of exenatide. So I have been using GLP-1 agonists like the OG GLP-1s, so where they had to be given 2 or 3 times a day. So I don't necessarily feel that the drugs themselves, at least as a class, are new. This was me back in medical school 20 plus years ago, and starting these medications and then into training and now the development of these, second and third generation GLP-1s. I do think, though, that there are a lot of unknowns for long-term use of these medicines, but we do know that if we can decrease the kids' weight, revert them into normal glycemia, that down the line has been proven to have a lot of implications of lowering complication rates. And so, I as one that does prescribe these on a daily basis, multiple times a day, I think I see where people have an uncomfortableness, but I also see the potential that, because of the adult data as well, you're lowering risk for cardiovascular disease in the same degree as adding a statin to someone's, cardiovascular regimen. So we had this same sort of, I think, concern about statins 10, 20 years ago. I think we're starting, it's just starting, and it's going to take some time, but I do feel still very positive about these drugs, overall. And that's really why I talked about sort of tailoring it to the right patient. It's not for everybody. And I have patients that have horrible GI side effects, and I would not ever continue that, these drugs in those patients. But for some, I mean, I have some that do great. I've actually been able to take them off of GLP-1s. They reverted back to normal glycemia, and we are able to monitor and maybe try other medications, oral medications for them, and not even be on GLP-1s. So
Thanks.
thanks.
We've got a couple of questions in the chat. This one is from Jean Welsh. Thank you for a very interesting overview, Dr. Shah. I'm wondering what you know about what is being done in the pediatric primary healthcare setting. Is enough being done to identify the kids at risk early enough? Do you have a sense for what proportion these kids are getting referred to endocrinology? And lastly, or followed up adequately by the primary care provider?
So this is super important from a primary care perspective. I do think that, at least again, from the year that I've been here and the understanding of the referral patterns that we get, and as really the children's hospital for the state, we get a lot of referrals. And Dr. Riley can probably share in this in terms of how many referrals we get for prediabetes and for kids that we think are at risk or right at the threshold for type 2 diabetes. There's really great screening with A1Cs. And so I think that they are getting referred. That's a big point. But then the follow-up, I also do think that there is pretty good follow-up as long as the family is plugged into that, primary care provider, because we see serial A1Cs whenever these kids get referred. So that they're paying attention to the fact that, oh, screening needs to be done, and this kid has obesity and has risk. So.
All right, last question from Muhammad Ali. Great talk, Daniel. I wonder if you can comment on type 1 treatments, and also, if kids aren't young adults, is there any research program specifically for kids rather than just trying adult meds in kids?
Wow. That is a great question, Mo. I mean, there are no drugs that I know of that are being tested specifically in children that have not gotten some sort of approval or conditional approval in adults. And I really do feel like that's just the FDA mandate, that these drugs have to be tested in children, and certainly the safety profile in adults, and then understanding the PK and PD aspects of these drugs. So not that I'm aware of. And then you wanted to comment on type 1 treatments, Mo? I don't know if
I think so, yes.
Okay, so just treatments for type 1 diabetes specifically, or that's why I wasn't.
Yeah, just as type 1 treatments.
Yeah, so just to say that, again, maybe it sounds like another talk potentially, because we are working and developing to be able to give these biologic medications to prevent the onset of type 1 diabetes. There is a specific drug called Tzield that is FDA approved, and we will be infusing that medication, particularly in probably the next month or two. But identifying kids we can identify these kids because we can check for antibodies. And so if they have 2 or more antibodies that are positive, they could qualify for this medication to help delay the onset of type 1 diabetes. So with it, again, it's an immunologic therapy that really stunts the immune system. And so that's what's coming actually for type 1 treatment. And so there's going to be multiple different agents for that as well come in.
All right, I think that is it for the questions. Thank you so much for your talk, Dr. Shah, and your insightful information.
Great.
And that will conclude our talk.
Great. Thank you all. Thanks everyone for attending.